Hello. So, first of all, I think we all should give a nice round of applause to Dr. Smith, because it's her vision that really has brought us here today. And then I think you guys should also give yourself some acknowledgement, because you are what I call the frontiers of medicine. It's hard to self-congratulate yourself, isn't it? But in all seriousness, I think that we are in a very critical period of medicine. And if you just look at financially what's happening in the world of Medicare and everything else, we're spending the bulk of our healthcare dollars on people really at the end of their lives. I mean, I think there's a huge mismatch in the ratio of how much money is spent on people who probably never make it out of ICUs. I was a chief of neurology at Bronx Lebanon Hospital for many years, and we see people come in with end-stage renal disease, hypertension, stroke, HIV, dementia, in septic shock, and we probably spend millions of dollars on patients with injuries that probably will never ever see the light of day. And yet, if we were able to shift our paradigm to focus on early detection of disease and make interventions that are meaningful to address the underlying pathophysiology of what is actually contributing to these chronic diseases, we could really save our government a tremendous amount of money. And I think your being here, I think, is the recognition of that. I was actually, before the break, I was speaking to one of the attendees here who told me that he's friends with the American College of Preventive Medicine. I didn't even know that such a group existed. And he said to me, the problem with the American College of Preventive Medicine is that is the American College of Preventive Medicine, meaning that there's really not this kind of paradigm shift that's required for us to begin focusing on disease prevention at early stages rather than later stages of disease. So I think it's great that you're here today, and there's obviously a long learning curve for all of us. And one of the things I could tell you that, when Pam asked the question, how many of you are confused about, brain chemistry, and you all raised your hands, that's actually a good sign, not a bad sign. I think that, the learning process itself really requires us to operate in the space of not knowing. The more I learn about brain chemistry, and this is what my research and my focus is on, the more confused I become, not less confused. And I think that's an honest appraisal. But I do think that as we go along this lecture, the next couple of time we have this afternoon together, is to kind of focus in on some of what I call the take-home messages that I think are critical for you to operate in some level of comfort when you see patients with either depression or other psychiatric or neurological diseases. So I'm curious, just by a show of hands, how much relevance do psychiatric and neurological problems have in your practices right now? Is it something that is a big part of the practice, or a small part of the practice, or not a part of the practice at all? Large part. Okay. What's that? It's a right, 70%. Well, it's probably like 100%. And the reason is that nobody leaves their emotional or their neurological state of being in the waiting room. All disease processes, whether we're talking about a direct identifiable psychiatric problem such as depression or anxiety, or systemic disease processes like cardiovascular disease or inflammatory diseases, the recognition that there's this bidirectional operational relationship between our systemic biology and our brain chemistry and our brain health is really indisputable. And I think that this Cartesian duality that's really kind of enmeshed itself in Western culture, where psychiatry treats mental health problems and internists treat physical problems, is a great disservice to treating patients holistically. And I think one of the major take-home messages I would have for you is that to begin thinking about when you see a patient with hypertension or any systemic disease process, what is operational from the cognition or the emotional phenomenology of a patient. Appreciate then psychiatrists are, how does systemic biology affect our psychiatric and our mental health and our emotional health, and really recognizing this is a bidirectional effect. What we're going to talk about today is identifying neurochemical imbalances in patients. And there are a couple of caveats here, and the caveats I want to make to you are as follows. The most specific way of learning these tools on how to address a patient's neurochemical imbalance really is never forgetting that communication with patients is primary. If you want to take shortcuts and think that by doing some type of biochemical assay is going to give you answers that you cannot get more readily from actually talking to patients, then this lecture, you probably should close your ears and not listen to this lecture at all. Because the reality is that every patient, if you listen carefully, will tell you specifically what's wrong with them. It's asking the right questions. It's also understanding that although it's very complicated, that patients psychiatrically operate in certain types of behavioral phenotypes that you can recognize. And one of the goals I'll have to talk to you today about is recognizing behavioral phenotypes. Understanding that the DSM criteria for psychiatric problems is arbitrary. Patients don't say they have 5 out of 8 symptoms in a checklist, therefore they have major depression. If you have 4 out of 8, you're not major depressed. Homosexuality used to be a DSM psychiatric diagnosis. They keep changing DSM because obviously this idea of creating categories of mental illness is purely arbitrary. So that's the first point. The first point really to emphasize to you is take good histories, listen to patients. There are no shortcuts. The second caveat is that most of the available diagnostic tests that are being commercially exposed to are really, quite frankly, exploitive and have very little value in terms of the relationship or the association to psychiatric diseases. I'm involved in some very, very interesting research, which I'll show you today, called Genome-Wide association studies. This is looking at thousands and thousands of patients with psychiatric problems, whether bipolar disease or depression or schizophrenia. Very difficult to extract both a signal biologically as well as a strong effect size. But we'll go through each one of those, and I'll tell you what I think the leading, most promising areas are that can be used as an adjunct for your practice. And the caveat here again is adjunct, that one should remember that when you are applying diagnostic assessments, at least in psychiatry, that really the history and the listening to patients are primary. So this is the post-genomic era. We know that this shows you how difficult this is to kind of, the needle in the haystack. There are about 20,000 genes. There are hundreds of thousands of transcripts based upon the RNA of each gene. And when you start looking at these single nucleotide polymorphisms, by the way, does everyone know what that terminology means? Should we go over that a little bit? What are single nucleotide polymorphisms? So let me just give you an example. If you don't know what that means, if you have a name, my name is Jay Lombard, right? And let's say that's a gene. And that gene programs that I'm 6'2", and I'll be 50 years old, and I'm a neurologist. If instead of it says Jay Lombard, it says Joy Lombard, okay? And you misspell my name, maybe I won't be able to get on a plane flight, right? Because the person at the gate will say, you're Joy Lombard, not Jay Lombard. So these single nucleotide polymorphisms are very subtle substitutions within the DNA of nucleotides, where adenosine could get substituted for thymidine or guanine for cytidine. And those slight polymorphisms produce changes that are not lethal genetic defects. So for instance, cystic fibrosis or Huntington's disease are lethal gene mutations. These are subtle abnormalities, but these subtle abnormalities change behavior of proteins downstream, and that there have been literally hundreds of associations, not just in psychiatry and neurology, but also in other diseases, cardiovascular disease, hypertension, diabetes, obesity, cancer, in which looking at single nucleotide polymorphisms are associated with disease states. Now, the next question you should ask yourself, though, is so what? So if we spend $1,000 or $500 on getting an assessment of our patients' single nucleotide polymorphisms in depression or in any other disease process, Does having that information make a difference? Can we demonstrate that knowing a priori that a patient has polymorphism, does that or will that change how you manage the patient? So I think you should always ask yourself that question when you start thinking about testing. How does information that I have change my management of a particular patient? And that becomes very important in psychiatry because those questions are difficult to answer. They're honestly difficult to answer. So we're going to look at this a little bit more detail, but keep in mind how complicated this picture could be. And, you know, where exactly are we here, right? We know that there are, you know, literally hundreds of thousands of metabolic steps. I actually like maps like this. I mean, I'm a little bit of a neurochemical geek. I like figuring out what pathways are abnormal, but I think they won't invite me back here if I don't give you sort of take-home messages that you can operate on beginning Monday. But right now, you're there. And my goal is to take this map and to make this map clinically useful to you so that on Monday morning, when you start seeing patients with neuropsychiatric problems, there's clinical applicability. And if I don't do that, then you should be asking me to do that for you today because there's a lot of information here